Yes.
So we now move on to the next drug review and therapeutics talk, and that is anemia in type 2 diabetes, a subject that is often ignored and not talked about much and not treated and looked for. So to take us through this important session, we have with us Dr. Anirban Majumdar, whom I would like to introduce now. He is professor at the KPC Medical College and Hospital, Kolkata, and is also the conjoint professor, School of Medicine and Public Health, the University of Newcastle, Australia, and he's the fellow of the Indian College of Physicians. He is also a ACE fellow, and also has an FRCP. He has good number of publications, both national and international, and has been a principal investigator for clinical trials. So I present before you Professor Anirban Mazumdar to talk on anemia in type 2 diabetes.
Thank you, Dr. Neeta. May I share my screen? Okay, I think. Is the screen visible?
Yes, it's visible. Please put it in screen show mode.
Yes. Is it all right?
Absolutely. Please.
Okay, thank you. So I'm going to talk about the anemia in diabetes. I convey my sincere thanks to the organizer for inviting me, and also to the MQ who has actually sponsored this talk. But importantly, this is a very good topic, and as Dr. Pandey has already introduced, that we actually conventionally don't evaluate the anemia among our type 2 diabetic subjects. Now, if you look into this important publication, it's just the same what Dr. Pandey has already pointed out, that it remains unrecognized, often undetected, and very, very importantly, even if it is detected, people are not actually treating those anemias in their clinical practice. So therefore, most of the patients with diabetes are rarely tested for anemia. And number two, if you at all tested for the anemia, if you find that there is an anemia, then very small number of patients receive the treatment. Majority of the situation, they don't receive any treatment, even though we know that the anemia has got a significant impact on the quality of life of the patients of diabetes mellitus. So let us have a look into the impact of the anemia on HbA1c. Now, HbA1c level increases in iron deficiency anemia because the RBC lifespan goes up, and that is why the HbA1c value goes up. So screening for anemia before commencing treatment for diabetes is better. If you are diagnosing the diabetes on the basis of HbA1c, then you may be wrong if you are actually diagnosing on the backdrop of anemia. And when you are setting a treatment target on the basis of HbA1c, then anemia must be corrected beforehand. Otherwise, you actually are giving a wrong target in front of your patient. And strict HbA1c control is not recommended unless and until your anemia of your patient is well corrected. So with this small introduction, let us have a look into the prevalence of anemia in our country. I will also evaluate the impact of anemia on diabetes complications, the pathophysiology, some of my experiences, and the take-home message. Now, if we look into the prevalence of anemia in our country, it is almost everywhere. You will find in the children, in adolescent girls, in women, in pregnant women, including in the men. We have a roughly around, say, 50% of our population have anemia. It is slightly less among the men, slightly higher among the women. That is true, but the anemia is very, very prevalent disease in our country. And 2 to 3 times higher risk of anemia in patients with diabetes than those without diabetes. Second, the patient, those who have poor glycemic control, they are at higher risk of developing the anemia. And third, if you have a renal disease in the backdrop, we all know that the anemia and chronic kidney disease are very intimately linked, and therefore the risk of anemia further increases with the onset of kidney disease among our type 2 diabetic subjects. Now, looking into the screening of anemia in diabetes, this is the categories of anemia. This is conventionally, we divide the anemia in mild, moderate, severe. So the simple test that we can do is just get a complete blood count. And if you get a blood count, you quite naturally, you can identify the presence of anemia, number one. And number two, you can categorize the anemia, whether it is a microcytic anemia, it is a normocytic anemia, or it is a macrocytic anemia. And on the basis of that, you can further progress to your evaluation, and actually we can address the problem. We at the same time will evaluate the comorbid condition, as we know that the chronic kidney disease is a very, very important factor which can lead to the development of anemia. And we'll also have to look into the medication history. The very, very important drugs which are associated with anemia in the diabetes is topmost cause is the metformin, definitely, because it causes B12 deficiency. Now we have the AC inhibitor ARB that can cause also anemia. And third is that the pioglitazone often can cause some kind of dilutional anemia among our patients. Now, looking into the impact of the anemia on diabetes complication, we know that the diabetic patient has got anemia. The prevalence of anemia is 2 to 3 times higher among our diabetic subjects. But does the presence of anemia has got any impact on the diabetic complication? Now, this is the study which actually showed that this is one of the many studies which actually showed the importance of the anemia in the risk of progression of diabetic nephropathy. So anemia is a risk factor. So if there is an anemia, there is a more progression of diabetic nephropathy, there is more progression of retinopathy, and therefore if you look into the microvascular complication, all the microvascular complication, neuropathy, nephropathy, retinopathy are closely linked with that of anemia, and the prevalence of anemia is higher. And it is not that the prevalence of anemia higher among patients with microvascular complication, but the important fact is that the presence of anemia is associated with more progression of the microvascular complication. And then we have this very, very important publication that anemia is a risk factor for cardiovascular disease. And there are numerous publications of the link between the anemia and the higher cardiovascular events among our type 2 diabetic subjects. And I have taken two publications from two sides, one from the nephrology side, another from the cardiological side. And both categories of the publication actually showed that the anemia is a very, very important risk factor for the cardiovascular disease or events. Not only that, this important study has looked into the mortality with respect to anemia. You may say that the patient, those who have anemic or those who have anemia, they have higher comorbid condition. Yes, but this study actually done after adjustment of the other independent predictor, and the anemia was associated with a 57% increase in mortality, and this is an independent predictor as far as the mortality is concerned. So therefore, what we have come to know that the diabetic patient have higher possibility of anemia. This is number one. Number two, if you have anemia, the progression of microvascular complication will be more. If you have anemia, there is a high possibility of cardiovascular event. And number four, that the patient who have anemia has got a higher possibility of death. So there are a lot of factor, a lot of importance as far as the anemia is concerned in the backdrop of diabetes. Now, why there is anemia among our diabetic subjects? So there are a lot of mechanisms. It is not a single mechanism. I have already discussed about the presence of chronic kidney disease. All of us are aware that the presence of chronic kidney disease is associated with more prevalence of anemia. Now, with a progressive fall in the GFR, you can see there is a progressive rise in the prevalence of the anemia, both in type 1 as well as in type 2 diabetic subjects. Now, if we look into the possible contributing factor to the anemia among patients with diabetes, the topmost cause is definitely the chronic kidney disease or the reduced renal production of erythropoietin. But the other factors are also there: reduced red cell survival, the deficiency of the iron, and then the systemic inflammation. The obesity itself can cause system inflammatory process, and the anemia of chronic inflammation can develop in the backdrop of significant obesity. There may be occurred blood loss. Many type 1 diabetic patients have celiac disease, and as I've told you, there drug therapy, many drugs which what we use in our clinical practice for the management of the diabetes are associated with anemia, and also there the possibility of hemodilution. Now, after bariatric surgery, the anemia is a very, very important issue. Many people, those who are seeing patients after bariatric surgery, must have experienced that anemia is a very, very common issue, because 2/3 of the patients who had bariatric surgery suffers from anemia, and iron deficiency is one of the very important cause, and therefore it is recommended that all patients who had bariatric surgery should receive iron supplementation for a long period of time. Obesity itself can cause chronic inflammation, may be responsible for the anemia of chronic inflammation. And then there is some other micronutrient deficiency, which is also common after the bariatric surgery, especially the zinc, copper, and also the deficiency of vitamin B12 and folate. So after bariatric surgery, people actually advise lot of supplementation, including iron, to prevent the deficiency disorders, including the anemia. Now, another important fact which I have mentioned about the effect of AC inhibitor and ARB, which we commonly use among with our type 2 diabetic subjects, both those who have a renal disease and also those patients who have hypertension. So almost all our type 2 diabetic subject receives either AC inhibitor or ARB, and they actually have a effect on the hemoglobin level, and they can cause anemia. So therefore, looking into the cause of anemia among our type 2 diabetic subjects, it is not a single factor which is responsible for the development of anemia, but a multiple factor which are responsible for the development of anemia. Chronic kidney disease is at the top of the list. The presence of chronic hyperglycemia, abnormal RBC lifespan, use of the drug, malabsorption, especially vitamin B12 deficiency when you are using metformin, chronic inflammation of obesity, from obesity, maybe testosterone deficiency. So all these factors cumulatively actually contribute to the development of anemia. They reduce erythropoietin production, they produce some functional deficit of erythropoietin action, and all these factors leads to the anemia. Coming to a few of my experiences with the anemia. Now, this is a 34-year-old woman who have diabetes for the 4 years, hypertension, and normal periods, mother of one child. She was on metformin 1 gram and glimepiride and telmisartan. She had some kind of dyspnea on exertion, BMI 29. And when we evaluated this patient, we found that she had significant anemia with hemoglobin 8.7. Other parameters are more or less normal. HbA1c was slightly higher, but otherwise the patient was more or less perfect. Now, when we look into the anemia among our type 2 diabetic subjects, how we should proceed, this is basically a diagnostic approach for the anemia. As I have told you, we have to look into whether the patient has microcytic anemia or normocytic anemia or macrocytic anemia. Now, if the patient has got a macrocytic anemia, so quite naturally, it is possibly because of vitamin B12 or folate deficiency, maybe drug induced. Say, for example, patient is receiving metformin for a long period of time, may be associated with hypothyroidism, because 10 to 15% of our type 2 diabetic subjects has hypothyroidism detected or undetected, and liver disease or chronic alcohol use may be the other factor. Now, those who have a normocytic anemia, it may be because of iron deficiency or vitamin B12 deficiency, but they are basically of anemia of chronic disease or chronic inflammation, maybe because of some infection. And then we have the anemia with microcytic. A microcytic anemia is commonly because of iron deficiency or thalassemia. So what we have to check, we have to test the ferritin level. When you find that there is a microcytic anemia, the next best test is the ferritin. If the ferritin is low, it is iron deficiency. If ferritin is normal or high, possibly we are dealing with the thalassemia or the thalassemia trait. Now, coming to the evaluation of this particular case, we find that this patient has got a mean corpuscular volume 74.7. That's quite low, microcytic anemia. So it is possibly because of iron deficiency, because the serum ferritin value was also very low. So how we should treat this patient? The patient is usually treated with the iron supplementation. Now, what should be our target hemoglobin? Now, this is basically a position statement which said that we should target based on the age, clinical status, and treatment response. Very important to understand that in the backdrop of chronic renal disease, we usually don't target more than 11. So your target should be around 11ish because if we target more than 11, there is a possibility of adverse events in the backdrop of diabetic kidney disease. So usually we do not target more than, at least more than 12. So we should target about 11, 11ish, maybe up to 12. So if it is more, if the HbA1c go beyond 13, there is more possibility of cardiovascular events and mortality. So in other situation, the target will vary according to age and clinical status, but in the backdrop of chronic kidney disease, our target will be around 11. Now we should treat the patient with iron in an iron deficiency anemia. Either you can give orally or we can give intravenously. There are a lot of preparations available in the market as far as the oral iron preparation is concerned, as far as the IV iron preparation is concerned. We conventionally use the ferrous sulfate. Nowadays, the other available preparation is there in the market. They are actually cause less GI side effect. The most important side effect of iron, all of you are aware, is the GI side effect. So the compliance becomes low. And when you are giving iron then orally, then you have to give it for a very long period of time. However, oral iron preparation has many advantages because it is effective in most of the situation. It causes low risk of side effects and cost is very low. On the other hand, if you want to give IV iron preparation among the patient, those who are not responding to the oral iron therapy, then you can give the ferric carboxymaltose. That is a preferred preparation nowadays, and we give roughly around 2 doses of 750 milligram or 1000 milligram dose once at a time. It is effective for most of the patient very rapidly. It corrects the anemia, resolution of the symptom, compliance is assured, no GI side effect. However, you have to monitor the intravenous infusion. There is some rare cases of allergic or infusion reaction, and you have to supervise this infusion, and the cost of therapy is high. So it means that the oral iron preparation has its own advantage and disadvantage. Intravenous iron therapy has got its own advantage and disadvantages. Coming to the second case, almost same case, but the issue is that this patient has got the HbA1c same 8.7, except that the mean corpuscular volume is low, but this patient has got a very high ferritin 167 or the normal ferritin level. So when there is a normal ferritin level, it indicates that we are not dealing with iron deficiency anemia, and therefore we have to look into the other cause of microcytic hypochromic anemia. And the second most important cause of microcytic hypochromic anemia is the presence of thalassemia. Thalassemia minor is quite common, or thalassemia trait is quite common in our country. We have diagnosed thalassemia even after the age of 40 or 50 in many of our patients. So we have the second most important test we can do is the hemoglobin electrophoresis. When you do the hemoglobin electrophoresis, you can actually diagnose thalassemia minor. And if a patient has got a thalassemia, the first thing we should do is to avoid giving any iron. This is the first step. The second is we can start the folic acid supplementation, and if a patient has got a concomitant iron deficiency, then only the question of iron supplementation will come. Otherwise, we don't give any iron supplementation. The very important issue is to look into the genetic testing and counseling, especially for the patient those who are in a childbearing age, because that has got a very important issue when we are dealing with a beta thalassemia minor. Now coming to the third case, this is a 62-year-old presenting with fatigability, dizziness, dyspnea during moderate effort, diagnosed with diabetes mellitus in 2010, on metformin therapy 1 gram twice a day with sitagliptin 100 milligram once a day, on beta blocker, no alcohol abuse or smoking, BMI 29, and you can see hemoglobin again. We can take 8.7. That's very low hemoglobin, and when we look into the mean corpuscular volume, it was high. It means the patient is suffering from macrocytic anemia. There is no iron deficiency. Serum ferritin level is normal. So what is the cause of macrocytic anemia? As I've told you, in most of the cases of diabetes, macrocytic anemia because of malabsorption of vitamin B12, and often related because of the long-standing use of the metformin therapy. So this is the topmost cause is the vitamin B12 deficiency as far as macrocytic anemia is concerned. So we have looked into the vitamin B12 level and also the liver function test, because chronic Alcoholism also leads to vitamin B12 deficiency, and many of our diabetic subjects do consume alcohol. So I've looked into the liver function test. It was absolutely normal, but vitamin B12 deficiency was actually vitamin B12 deficiency was there. So now how we should treat this megaloblastic anemia or macrocytic anemia? We may stop the metformin therapy because in most of the situation it is caused by metformin. However, if you're using metformin with a high dose, 2 gram, and you are using metformin for a long period of time, say more than 4 or 5 years, then and then only the possibility of megaloblastic anemia appear. And this particular patient was receiving metformin for a very long period of time and with the dose of 2 gram. So therefore the vitamin B12, the stopping metformin is maybe an issue in front of us. And second is we may start the insulin therapy to control HbA1c, and we have shifted and we have started the vitamin B12 replacement in intramuscular injection, initially 1000 microgram per week over the first 2 months, then the every 2 weeks, 1000 microgram every 2 weeks. So that is the recommended dose. So let us have a look into the metformin use and vitamin B12 deficiency. It is usually found among 10 to 20% of the patients who are using metformin in type 2 diabetes subject. Metformin actually decreases the absorption of the vitamin B12 from the GI tract. When you're using 2 gram dose for a long period of time, then there is a possibility of developing vitamin B12 deficiency, and there is a 13% increased risk of vitamin B12 deficiency per year of total metformin use at 13 years since randomization. This is the Diabetes Prevention Program outcome study. Now, this is a mastermind study which has looked into 2 randomized controlled trial, ADOPT and Eucapedias, and they have looked into a real-world study also, GODARS. And these 3 important studies, they have evaluated to see the impact of the metformin use with the prevalence of anemia, and they have found that the use of metformin is associated with higher possibility, almost 2 times higher possibility of anemia compared to sulfonylurea use. And in UKPDS, it was found to be almost two times increased possibility, or 3 times increased possibility of anemia with the use of the metformin. And similarly, it was found in the real world study also. So in the RCT as well as in the real world study had shown that the use of the metformin is also significantly associated with increased risk of megaloblastic anemia. Coming to the case number 4, a 54-year-old woman with a diabetes for the last 14 years, hypertensive for the last 12 years, mother of 1 son, and on gliclazide and linagliptin, amlodipine, mild dyspnea on exertion. And we find that this patient has got a 8.7 hemoglobin with creatinine 2.7. So it clearly indicates that this patient has got a chronic kidney disease, and that chronic kidney disease leads to the anemia. So we know the chronic kidney disease is very commonly associated with the development of anemia. So this study has looked into the progressive low eGFR and the progressive rise in urinary albumin excretion ratio are intimately associated with the prevalence of anemia. Combination of the two is associated with a higher possibility of the anemia. So if you have very low eGFR, if you have very high urinary albumin excretion, then the possibility of anemia is the highest. Now, why there is an anemia in chronic kidney disease? Erythropoietin, all of us are aware that the erythropoietin is a very, very important issue. It is produced by the kidney, and that is also responsible for the generation of RBC, because they are very, very important erythropoietic factor. And second is that the hormone hepcidin, which is produced by the liver, and hepcidin is intimately associated with the absorption of the iron from the GI system. So high hepcidin actually inhibits the absorption of the iron from the gastrointestinal system. Third is that the uremia can inhibit the erythropoiesis. The RBC lifespan is shortened in a uremic state. And lastly, there may be increased blood loss, because the CKD patient often have GI blood loss. So there are multiple issues which actually contribute to the development of anemia. Now, coming to this particular patient, on further workup, we found that transferrin value is normal and serum ferritin level is normal. It rules out the presence of background iron deficiency. So many patients with chronic kidney disease may have simultaneous iron deficiency also, where actually we should give iron supplementation to correct the iron deficiency, and then we check the hemoglobin and then decide what we are supposed to do. So this patient has got enough iron store, and therefore we have to look into the other therapy to improve the hemoglobin. So the target hemoglobin, as I've told you, should be around 11ish. We will not target 12 or 13 or 14. If there is an iron deficiency, we should correct the iron deficiency before we start erythropoiesis stimulating agent. Now, there are two erythropoiesis stimulating agents we conventionally use in our clinical practice. One is epoetin and another is darbepoetin. I usually use epoetin. Usually we give 4,000 to 10,000 units subcutaneously once weekly, or 10,000 to 20,000 units every other week. So we start with 4,000, and then actually we can increase the dose depending on the response of the patient. However, the use of erythropoietin stimulating agent is not free of side effects. There are a lot of side effects: the rise in blood pressure, rapid rise in hemoglobin, thrombosis, cardiovascular events, and malignancy, and the presence of hypertension, uncontrolled hypertension, and the history of thromboembolic event are contraindication to start a erythropoietin stimulating agent. And there is a very important study which actually looked into the evidence for the correction of the anemia in the chronic kidney disease. There is no conclusive evidence that correcting anemia significantly improves clinical outcome in patients with CKD, especially if we look into these two primary composite outcomes, that is death and cardiovascular event. So therefore, the use of the erythropoietin stimulating agent in the backdrop of CKD should be considered with this understanding that it will not improve the death, renal event, or possibly the cardiovascular event. Rather, if we use the erythropoietin stimulating agent, it may cause increase in the stroke. So therefore, the evidence in its favor is not very strong. However, there are a lot of data which suggest that if you correct the anemia, there is an improvement in the quality of life. There is a reduction in the retinal exudates, macular edema. There is reduction in the hospitalization with heart failure, and there is a protection for the development of neuropathy. So you may have some benefit in microvascular complication, also improvement in the heart failure hospitalization, quality of life indices, but as far as death and cardiovascular event, there is no evidence that it will have beneficial effects. So therefore, whenever we give the erythropoietin stimulating agent, we should be very careful. So take home is that the in patient with diabetes mellitus, prompt detection and correction of anemia is important due to reduce the risk of diabetes complication, because they are associated with progression of diabetes complication, and to improve the quality of life. Iron deficiency, thalassemia, trait, vitamin B12 deficiency, diabetic kidney disease are the four major cause of anemia and diabetes, which needs to be corrected. Treatment with oral or intravenous iron preparation and erythropoietin stimulating agent needs to be individualized based on the patient clinical status and comorbid condition and risk. And excess correction of anemia, especially with erythropoietin stimulating agent, could lead to adverse outcome. I stop here. Thank you very much for your patient listening.
Thank you so much, Dr. Mazumdar, for that very comprehensive review of anemia in type 2 diabetes, a very important aspect, and you've covered it so very well. I do not see any questions in the chat box, and I would like to thank you at this point for being a part of IDEC 2021. Thank you so much.